It's the very first thing, double vision or blurred vision.
I understand double vision, but
Yeah.
what about blurred?
I think it's all the same. I don't think there's any difference between that at all.
By double vision, do you mean diplopia?
Not necessarily.
Because that's what I mean. You see,
Yeah,
you
yeah,
must understand what we're talking about.
No. Normally double vision is diplopia, but with food poisoning you do get other visual effects as well. So there is one patient that reports that the world tipped 90 degrees to the side. Her vision made everything in the room turn 90 degrees.
Okay.
So that's not diplopia and it's
Yeah.
not blurred vision, but it's botulism symptom. So,
Well, anyway, I have one patient right now that I've known for years. I've injected her for years, and she's certainly a straight person. After the last injections, the usual upper third has developed in one eye only very significant blurred vision, which is bothering her terribly. I talked to her this morning. She's 2.5 months out, and she's beginning to recover. But I found that in the literature. So
it is a known side effect, and it obviously has got something to do with the muscles in the area, but I can't explain it other than that. Sounds like there's been a leakage of toxin to other muscles.
Yeah, but where to? Because that's what the ciliary muscle or what? I mean,
Is there any antidote to use?
Sfocato.
Because I have read that there is some metalloproteinase that reduce the action.
Di sensibilità ridotta
No, there's no antidote known for it.
No.
You're trying to work on the symptoms rather than the cause. You can't affect the
I
toxin.
believe that someone had this antidote for the...
Yeah, there's lots of guys like zinc, probably zinc. Something that takes zinc away might be a good antidote. Ptosis, of course, is the main issue, the one big issue of side effect in aesthetic. This is just some comparisons between different studies, repeat treatment on the right, single treatment on the left. There's really no difference between the products at all. And this level of ptosis in clinical trials, I don't think would be acceptable in clinical practice. If you had 5% of your patients with drooping eyelids, I don't think you'd be very pleased. But this is a clinical trial setting, and of course even the most tiny, minute droop will be recorded. So, and again, his hematoma, bruising, or local pain, some local irritation. There has been one report for a Chinese toxin of someone reacting very badly to it after injection, so we put that aside. For Dysport, there's been one report of an interesting side effect, which is that every time the patient was injected, they came up with a lesion on their nose, and then it would disappear, then they would be re-injected and the lesion would come up on the nose, and like that several times. I can't explain anything like that. I've got no tools to explain that, but that was published some years ago. It would not be possible. It would not be possible for anyone to react to the human albumin in the product.
why not?
Because that's a human protein, and so they would be self-immune, autoimmune. It's a human protein which is commercially available as human albumin that you buy. It's the same grade, same quality. So of course, if you're immune to that, you're immune to your own albumin. What you could be immune to, what you could be reacting to is the preservative in the albumin. That is a possibility, an excipient in the albumin. But not the albumin as such.
So what is the real effect of the albumin in the product?
Stabilizes it for shelf life.
Till the preparation.
Yes.
Till the preparation.
Yeah, that's all it does.
Okay.
Yeah.
And so when I inject botulinum toxin, even albumin. Okay.
Yes.
But
Like vaccines.
yes.
The same.
But I have seen that in the mass preparation there is a huge quantity of albumin,
Yes.
respect the sport of the other one. 1 milligram instead of some micrograms. Okay, so we have a lot of much more possibilities of allergy or immune response to the albumin.
I don't think so. I think it will be, because don't forget that this albumin is the product that you give like a burns patient. You give hundreds of milliliters to them. You give huge amounts of that albumin. It's a normal, natural human protein. And if people develop allergies to it, I think they would be, in real problems. The excipient, yes, I would accept there's preservative in it, in albumin. But that's how Merck's have got the stability of their product. They've just increased the amount of albumin.
They take off the protein, the accessory protein, and then put inside someone else.
They've taken out the natural protein and put albumin in. Of course, that's all it is.
Yes.
Yeah, there's no difference there at all. Yeah. But there's no doubt you could increase the stability of any of the products by just adding more albumin. That's it. The FDA actually published a review of side effects to toxin in 2005, and they looked at aesthetic as well as therapeutic. So over this period of just not quite a year, they had 1,000 reports of adverse events to toxin, aesthetic toxin. And of those, only 36 were serious. And when you look down at it and they analysed it further, they found that 13 patients had some really serious underlying disease as well. Okay, so there was a cause for some of those. And in fact, lack of effect was the biggest side effect. This is the trouble with the States. They report lack of effect as a side effect. In the way for like a dermal filler, one of the fillers, in America, if you accidentally drop the filler onto the patient's skin when you're injecting, that's a side effect. You have to report that to FDA. Believe it or not. And ptosis and headaches. So you see, there was nothing in all of the side effects. There was nothing that now, 8 years later, we wouldn't expect. Antibodies. Antibodies, are they an issue? And as I said this morning, I can only find 6 patients in the literature with antibodies. Just 6. 4 of them came from Germany, 1 from the United States, actually, and a 5th one from Germany as well. And when you look at the background and the history of these patients, some of them are unknown, we don't know. One of them, the patient was changed between products. And when they got to a certain product, they started to develop antibodies there. But you can't associate the product and the antibodies. That would not be correct to do. So, 6 patients. I actually don't know why we talk about it. If it was going to be 60, 600, 6,000, we would have seen them by now. We would have seen these patients with antibodies. Of that, I've got no doubt.
But when we do get a patient who stops responding, first of all, we can't measure the antibodies in our clinical situations, in our offices, so we can't talk about immunization or not. But we do have to give the patient an explanation, because he asks for one.
Of course.
So what is the answer? Because you mentioned product-related, doctor-related, but you also mentioned patient-related.
Yeah.
So what could be the cause?
When you talk to when I've talked to some doctors about this, they've got a patient, they don't respond, and you say, well, what did you do? What did you? And sometimes the explanation has come to me that when they sat with the patient for a long time, they discovered that there was some traumatic event in the patient's life. Maybe they got divorced, maybe they lost someone in the family, something happened, and they stopped responding. And when that trauma had gone, they started responding again. So there is clearly, I think, in some cases, a psychological link with the patient. I know that's a very difficult explanation to accept, but I think that is the case. I think that there is something in that. Also, a lot of the time I hear the patient phoned me up and said it hasn't worked. Have you seen the patient? No. The patient's told me it hasn't worked.
Well, that's a different story. We know about that.
But that
You
is
have to see it
yes,
yourself.
yes.
But you do see it.
Yes.
That's the whole point.
And I think then, you know, we get to the discussion about photographs, how important photographs are before and after treatment, because then you can show the patient, look. And I think there's a combination of these things as well. I don't think there's any one explanation. I couldn't give you one explanation. But if you have a patient that you think is really antibody positive, is really absolutely immune, write to me and we'll analyse the patient.
I wouldn't say he's immune. I'd say he's not responding anymore.
But we can analyse the patient.
Okay.
You know, we can put it in a test and we can tell you whether there's any antibodies in there. That we can do. No, and I'm only talking about neutralising antibodies, toxin neutralising antibodies.
I'm just wondering if we know all the antibodies out there. If there isn't something we don't know of which is acting, because truly clinically it's very unusual, but we do see these cases.
I think that there are two types of antibody response when it does happen. One of them is like a permanent antibody response, that the patient will not respond anymore. But we've had evidence, I've had evidence, I generated some evidence with a guy in the States some years ago, that if you took a patient that stopped responding, they had some antibodies, you left them a year, you measured them again, they didn't have any antibodies, you could treat them, then they developed antibodies again, and you couldn't treat them. So sort of every other year you could treat them. So sort of temporary antibodies respond. So permanent and temporary. Why there's a difference, I wouldn't.
Okay.
Some new uses. And I just mentioned a few of them.
Only one step beyond. This morning, you talk about the different reactions of the different effects of the botulinum toxin in different ethnical cases. No?
Yes.
But what you consider only the muscular strength, or also the thickness of the skin? How you consider different action in different ethnic?
I think all of those things. Thickness of the skin,
Yeah.
response of the skin,
Clinical.
muscle mass, and there may be some neurological differences at the junction level, things like that. There's a whole package of reasons.
Yeah, okay.
But clinically, there is data to show that they do respond differently. Yeah, I think of all of these, the most interesting at the moment is this group, dermatology and some of the rare diseases that are taking place, which are really, you could argue, a dermatology as well. I think that the new uses are quite fascinating. Why we don't know. But here's the depression data that I showed this morning. This is the depression information from Germany and other countries, which is, I think is very clear, but it's a small study, 14, 15 patients, 50 patients in each group. Very clear response. So is there anything else out there to support that? Are there any other data? Yes, here is a study from Doris Hexel that's just been published, looking at Botox, looking at glabellar lines, and looking at depression indices. And here are the people, the depressed group, and here are the non-depressed group. And you can see that there is a very distinct difference, very strong difference down there. I can show you these data from the States. Eric Finzi is very, very active in investigating depression. He's a very special guy because he's a very big believer in these new effects of toxin and other ways of improving people. He's a plastic surgeon and dermatologist as well. He's done a study.
He's the son of Finzi, the ancient dermatologist, Italian dermatologist.
Is he?
Yeah, I know.
You know
my
him.
question. There is an old dermatologist in Italy.
No, ma non è not the same.
No.
Finzi. Quello è Joran Finzi.
No.
Vabbè,
Finzi, sì.
And he published it in December at this meeting, at the oral presentation at the meeting, this study using 40 patients, 41 in the test and 44 in the placebo, and he got the same result. Near enough 30% of patients responded to this treatment. He has written this book. It was published earlier this year. And he has a very simple belief, and I think it's something that we really need to pay attention to, really detailed attention to. He believes very strongly that it is not the emotion in us that drives the face, but is the face that drives the emotion. In other words, if you can't look depressed, you can't feel depressed. If you can't look sad, you don't feel sad. And it's the opposite way round to what most people would agree. Most people think you feel sad and then you look sad. He believes it's the other way around. He believes that if we stop the face from having these emotions, we stop the emotions inside of us.
Well, that's Lewis's theory as well, but it goes both ways.
At the
He
same
says
time,
that if you interfere with smile, you depress people.
Yes.
That was one of the big
Yes.
issues we've had this year with the press.
This is not smile, of course. This is glabellar lines.
No, of course, but you remember 3 years ago he published positively about glabellar lines, and this year it was exactly the other way around with crow's feet.
But
But
Finzi,
the theory behind it is exactly what you just
Yes.
said.
but Finzi has found a group of patients that exist in the world with a syndrome called, I think it's called Möbius syndrome, where they have no facial expression at all. And he has questioned the Möbius people, and he finds that they don't understand what the emotion of happiness or sadness is, and they have no ability to make it. So when you start to put his picture together, I think you get a very interesting situation. It's become so interesting that now one German doctor is warning us not to do it, not to inject toxin in the face, because we're going to upset people's emotions. He's put a warning paper out last month in German, so we can't read it properly, to tell us not to use toxin in the face, because we're actually, if you like, messing up, tampering with people's emotions. But I think that this is a very interesting area of work for the future, and if it is true, the first cost-effectiveness study has been done on it as well a couple of years ago, and it's more cost-effective to treat depressed patients with toxin than it is to give them medication. So I think we're going to see a lot more of this, I think, in the future.
I noticed that botulinum toxin treatment is created as an addiction for the patient. Patients return every 6 years and they need to do botulinum toxin treatment, perhaps because they feel better from psychological way.
I think there's a huge mountain of psychology which we don't understand, but which we're walking around by doing all these toxin treatments, and yet someday we'll understand that we're actually truly, it's not aesthetic treatment at all, it's actually clinical, relevant medical treatment of people through the face, through affecting the face. Brilliant. Facial wounds, I showed this picture this morning. I think this result is very clear to me. This is a trauma unit, this is not an aesthetic unit, this is not a clinic, this is the accident and emergency unit where these patients come in and they've got a bottle in their head or they've had a car accident or something like that, and this is the result. And this girl, 17-year-old girl, it was one of the first patients that Dave Sherris and Holger Gassler treated. These are the two guys who really started the wound treatment thing. You can see she had a terrible accident. She's actually got a nice hole in her head here, and they did a flap, pulled it over. They gave her toxin, and a year later, you really wouldn't know. You really wouldn't know. So we've got now another area. So there's depression is one area, wound treatment, wound healing, even scar removal, hypertrophic scars, keloid scars, getting treatment with toxin. It doesn't work in every case. I'm pretty certain it's a dose thing, again, a dose thing. You get the dose right, you get the results right. But it's happening. Rosacea, the first trial's been published on treating rosacea. Steve Dayan is very interested in rosacea and inflammation and that whole thing in the face. Some other people have been publishing on facial flushing, menopausal facial flushing, and that works, toxin works in that as well. So the results here, they're okay, they're pretty good. 3 months, but a very low dose of injection, dose of units, 8 to 12 Botox units. Very interesting piece of work. Very.
Sophia, about it, what's your opinion about the anti-inflammatory power of the botulinum toxin? Because in literature there are some studies about the arthritis treatment, and I tried on my wife in the wrist, and it works. It works very well for many months. And I suspended the treatment with corticosteroids in my wife with 1 injection on the wrist of botulinum toxin. This is really exciting for me.
And
maybe the angiogenetic, I don't know, because I read if the botulinum toxin have an effect on the rosacea, on flushing, have another effect on the angiogenetic inflammatory steps.
I think that it has an effect on a range of neurotransmitters, but it also has an effect on hormones, and it also has an effect on other factors. So we do know that it will down-regulate some factors in the dermal layers directly. That's been demonstrated. So it doesn't only work through neurotransmitters, it has other factors that are going on. I'll show you a picture which is very interesting in a second. Psoriasis studies are going on. This is a mouse model of psoriasis where they actually got some quite good results. It's an interesting start, but nevertheless, there is a clinical trial going on in the States on psoriasis at this moment. Allergan are promoting a trial on psoriasis there. I showed the effect on sebum secretion. This had been noticed for a long time, but no one had measured it. They've now measured it. It's real. It's an effect. So in the dermal layers, we've now got a clear effect on the sweat gland. We've got a clear effect on the nerves because it's been used as treatment of pain in many conditions. We've now got an effect on the sebaceous gland, and we're now reporting effects on fibroblast growth and other factors in there. So there's 4 different new effects for toxin there. This is another different effect which has just been published very recently. I make no sweeping, no big comments about it, except to say that this is a breast cancer study, a breast cancer cell line, a very tumorigenic line down the bottom here, and normal breast cells at the top. This is done in the lab, and that's the result that you find after 24 hours. For some reason, it seems to be cytotoxic to breast cancer cells. It's a pretty good result.
Yeah.
For a first study, I'd love to get a result like that. I think many people would. And then finally, of course, my male pattern baldness, which is a real use of it. These two Canadian guys, they have a patent on it. They really believe that it affects not just, nothing really to do with hair, but to do with release of tension in the area and better oxygenation because the tension is released.
So you can believe that the action is on the vascular system.
Yes.
Right.
Yes.
Okay.
And that fits together with other things because in, for example, cancer.
But even on the sebaceous gland and the role of the sebum on the air. But I believe much more like minoxidil, for instance.
Yeah.
That we have an usual a part of vascular system on the air.
I would agree with you on some, but on the sebaceous gland, there's a nice little piece of work hidden away by a group from Italy, and I can't remember the main author now, and they looked at rat skin, and they took toxin and they pushed it into rat skin with iontophoresis, okay, using electrical currents, and then they stained for toxin in the dermal layers, and they found that the majority of toxin was associated with the sebaceous gland. A little bit with the root hair, a little bit with the nerve, you know, the erector pili that governs the rat hair movement, which we know when you give toxin in large quantities to animals, their fur goes all crazy. A little bit with that, but the majority with the sebaceous gland. So I've always felt that that was a good start on trying to understand sebum secretion effects, and now we have the other one.
Are you at all familiar with studies for Raynaud's phenomenon?
Oh wow, yeah. I've come across a study recently with it, but I couldn't possibly, I don't know much about, or if anything about that phenomenon, but it has been tested in that recently.
No, I know. Yeah. Anyway.
That's way off my beaten track,
Okay,
so
okay.
I'm afraid.
Well, that was superb. Thank you so much.
Thank you.
Yeah.
Qualcuno vuole chiedere qualcos'altro?
Inizio di casa.
Mm?
Inizio di casa.
Va bene. So, we're
I hope-
very,
I hope you've got some ideas from the last thing. Anyway.
If in the future the botulinum toxin, you will find a Viagra effect too, for the botulinum toxin, will be a great revolution, another revolution.
Yeah, but there's no muscles. That's the trouble. I don't know. It's
There are vessels.
I think that all these new uses, to me, the problem now is choosing what not to look at, because it's finding more and more uses. A lot of these things, you know, publication comes years after someone's been using it. So like sebum secretion, an intradermal, it's been used for years in that.
Do you remember this morning I showed the cover of a book that just came out? So the guy one of the two guys who wrote it is a good friend of mine, and he tells me that to him, he's a neurologist, one of the most revolutionary new applications which will impact treatment in an amazing way is chronic prostatitis.
Yes.
He tells me it's going to revolutionize urology totally.
Yes.
2 injections per year.
Yes.
Finished. No drugs, no nothing.
I mean, I haven't mentioned anything with
No surgery.
urology or anything. I mean, the whole urology area, with all its different applications, is going to be massive, there's no doubt. But I still believe that pain is the place where it will make the biggest contribution to medicine, generally, because we haven't really started much on pain at all. I'm completely convinced that if we understood pain more, we would understand how to use toxin better. But we really don't understand pain that well. It's all thought this and thought that. We might do this. And I don't think we understand it at all properly. And that comes recently, for example. It was always thought that certain types of migraine were due to vascular effects in the brain, in and around the head, in the brain. And just a couple of months ago, a group in America, I think it is, has published now about vascular effects in migraine. And they've done it all by MRI and quantitative scanning of all of the blood system. And there are no vascular effects in migraine that they have found. So what is migraine then if it's not vascular effects? It's pain molecules. It's CGRP, it's substance P, stuff like that.
Yeah.
And their work on the MRI of the blood system is very clear. There was no contraction, no constrictions that they could see.
What is it you were talking about this morning about a specific molecule being developed? Is it a big secret? Is it something you know?
No. I mean, there's several of them around, and they have different purposes. So we do know already that you can retarget toxin from SNAP25 to another similar molecule called SNAP23 by changing its binding ability. So that's been done. There's molecules there. What they're really trying to target is secretion. So they're trying to target asthma, rhinitis, all of those conditions by having a retargeted toxin through adjusting the binding of it. And it's been done. Animal models have been successful in the studies on retargeting the toxin. Other people believe that if you adjust the dimensions, the shape of the molecule, you can retarget it as well, and the evidence for that is a bit thinner.
So that would make sense on hyperhidrosis as well.
Oh yeah. I mean, we're going to see, some people call them designer toxins. I think that's terrible. I think they're engineered toxins. And some people refuse to call them toxins because they're not natural products. So why should we call them a toxin? Allergan have one in clinical trials now that's been developed for them by a company in the UK. And they're targeting post-hepatic neuralgia and insulin neuropathy. They're the two targets for it, so pain. It's in phase 2 clinical trials now. But the dose that you have to use is very, very high. It's nothing like real toxin. It's you're talking of dose in micrograms now instead of picograms. So that's already happened. That's why I think pain is going to be a big area, because if we can change the molecule for pain to retarget some of these pains that we don't understand very well, then I think we can achieve a lot.
Only a curiosity, your job now is to study new uses of the botulinum toxin A or other subtype of botulinum toxin?
No comment.
No.
Okay, that's fair enough. Okay, then. So thank you really very much.
Thank you.
We appreciated it tremendously.